I'm Brian Lindstrom, one of the senior neurology residents here, and it's my pleasure to introduce Greg Worrell for Grand Rounds this week for a couple reasons. But before I get to that, I was told, by all means, don't forget that we have applicants this week. So thank you for coming. Hope you enjoy the nice weather and tour of the institution. So those couple of reasons. First and foremost, we both grew up in the illustrative city that is the head of the Strategic Air Command. You know what that is? Also the home of aviation, Orville and Wilbur Wright, which is Dayton, Ohio. And the second reason is that...
I hope the second one's better than the first.
And the second reason that he's convinced me that there lies within the middle of the U.S. an oasis called Rochester, Minnesota, where I'm headed for fellowship next year. So we'll find out. I hear the winters are nice and warm with global warming, so look forward to that. But briefly, Dr. Worrell did in fact grow up in Dayton, Ohio, went to university at Wright State University, which is named after the Wright brothers, as you probably now gather. Did some Ph.D. in physics. He stayed in Ohio for that. But then after his Ph.D. in physics, went to Fort Worth, Texas for a job, and then actually served as a professor of physics for a little while before deciding that medical school was the next step. After which he ended up at Mayo Clinic for neurology residency and then fellowship, and where he has stayed and is now a professor in the division of epilepsy. On his CV, there's lots of other things, but he has an active research lab that involves issues related to ictogenesis and forecasting, as we've heard about a little bit in the last hour. And so now we'll hear a little bit more about focal epilepsy. So thank you.
Yeah, thanks, Brian. And if the applicants are coming to Rochester, it is a little cold, little chillier there, but
don't do any proselytizing.
I know. So I've already tried to recruit the current residents to epilepsy already. So
does Brian really have to wear a suit?
He's been asking me about this every week.
No. There are many myths about Mayo Clinic. One is the dress code. The myth apparently it involves all the way to the underwear and the socks, but I've never seen it.
And it never will in the winter.
But one thing that's not a myth, it's very cold in the winter. That's truly not a myth. Well, thanks a lot. It's really a pleasure to come, and certainly such a long, illustrious history of epilepsy and epilepsy surgery here at this institution. And really nice to meet with Brian and his family, your residents. So this is a pretty broad talk, and I apologize if I tell you a lot of stuff you already know. It's advances in the diagnosis and treatment of drug-resistant epilepsy. These are just some the guys in the lab whose stuff I'll talk about, in particular Matt Stead, who's now on staff, and he was my first fellow and has had a pretty good run. So starting at the beginning, definition of seizures and epilepsy. So seizures, they're transient occurrence of signs or symptoms due to an abnormal, excessive, or synchronous discharge of neuronal activity. And that's what the International League Against Epilepsy gives us for seizures. Epilepsy, then simply just a disorder of the brain characterized by the predisposition to generate seizures, so unprovoked seizures. Certainly a big development over the last decade is more of an appreciation of the consequences of the disease and the company that the disease keeps, and the cognitive, psychological, and social consequences of epilepsy are significant and is recognized now within the construct of epilepsy. So now this is the part where everyone in neurology, they should be doing epilepsy, because as far as I know, this is the disease where we've got it all. We've got medications. The list is over 30. We even have a dietary treatment that works, the ketogenic diet. So that's pretty cool. We have epilepsy surgery. We can cure patients. We have devices. So it's a pretty rich field and a lot of progress. So what do we know about why do we have 30 drugs? Well, it's because we still can't get all the patients seizure-free. And in fact, it's not only all the patients, a full third of the patients we can't get seizure-free. So in the US, there's roughly 3 million patients with epilepsy, about 1 million of them, despite your best efforts, taking multiple drugs twice a day, every day, will continue to have their habitual seizures. We now define drug-resistant epilepsy, and this is very useful because in the decision-making process, when do we start thinking of therapies such as surgery, devices? Well, we define drug-resistant epilepsy now after a patient's failed 2 drugs, and that's failed because of lack of efficacy, not because of side effects or complications. So 2 drugs. What we know from Patrick Kwan's work is that this is what you'll hear from the experienced clinicians. The best drug is the first drug. Doesn't matter what drug you pick, but you cull out the easy ones with the first drug. By the time you fail 2 drugs, the chance that the third drug's going to be successful in eliminating seizures is about 7% or so. So by the time you fail 2 drugs, these patients shouldn't be followed long-term trying crazy combination. You know, it's a combinatoric nightmare when you look at the 30 drugs you have. So patients deserve an early evaluation after they've failed 2 drugs. The idea for epilepsy surgery for focal epilepsy is that there's an isolated region of tissue that generates the patient's habitual seizures. We localize that region. Structural imaging, MRI, has really been the transformative technology in the last century that really changed how we took care of these patients. But electrophysiology remains very important, functional imaging. So we'll just do a couple of cases, and again, these are pretty straightforward, but I think are important and interesting. This is a 42-year-old patient with 15 years of drug-resistant epilepsy. You know, we used to call these complex partial seizures. I still have a hard time getting away from that, but now they're focal seizures with dyscognitive features. That's the new terminology. And this patient had a long history of epilepsy, and her MRI shows a cavernous angioma. This is a highly epileptogenic lesion and a surgically remediable epilepsy syndrome. This patient doesn't need another drug. This patient needs a neurosurgeon after they've failed 2 drugs. Now seizure-free for 10 years off medicine. Another classic case, focal epilepsy. This is mesial temporal sclerosis. And you'll see on this coronal MRI, increased T2 signal, or this is a flare image, but increased flare in the right mesial temporal structure, a little bit of increased space in the temporal horn. So this is mesial temporal sclerosis on pathology. Patient had a history of febrile convulsions, subsequent development of developed epilepsy, and again, an excellent surgical candidate. So just quickly, I know when I first learned about this, wow, so it sounds like, so there's this focus, you take this really small targeted strike, and that's how you do surgery. Well, it really doesn't work that way. The surgery in the non-dominant is often as much as 5 to 6 centimeters at temporal neocortex, and the dominant temporal lobe, maybe 3 centimeters of temporal neocortex. Often the amygdala and hippocampal structures are removed. And this is what that looks like on MRI. So it's not exactly a focal surgical strike. It's a pretty big resection. And probably one of the reasons that temporal lobe surgery is so successful, just the anatomy of the temporal lobe and that network, in particular medial temporal lobe epilepsy, surgically accessible, can be targeted surgically and removed. I was talking with John Miller earlier in the day. The laser therapy where you deliver a fiber optic probe into that tissue is a really nice example of a less invasive approach to epilepsy surgery. What about this case? So this patient has bilateral mesial temporal sclerosis. So you see this increased T2 signal. They have seizures coming from both sides of the brain, not a surgical candidate. A lot of the patients we see these days have normal MRI. So despite 3 Tesla, and we've been getting some 7 Tesla imaging as well in these patients, you know, it's always the hope that that next few extra Tesla will change the game, but it really hasn't. Really what we saw on 1.5 Tesla is much what we see on 3 Tesla. I think it's probably going to bear out even at 7 Tesla. Many of the patients have normal MRIs. So these are very challenging patients. This is a patient with left temporal lobe epilepsy, focal seizures with dyscognitive features, normal MRI. We take these patients, as do you, to surgery. This is a patient with extratemporal lobe seizures, starting with focal motor features, and I'll show you those. So I like this because this is an example of a particular kind of epilepsy that's really interesting, called reflex epilepsy. So this is a gentleman who, he's off his medicines in the EMU. This doesn't happen all the time at home. It does when he chews. In reflex to the chewing, he develops a focal motor seizure involving the left face. He's being injected here with an ictal spec injection. You can imagine that that would be a fairly debilitating disease, that when chewing, you would have focal seizures. Reflex epilepsies, there's a whole range of reflex epilepsies that are really interesting. Reading epilepsy, people had a college student that when they would read, that could induce seizures. Of course, the most common type of reflex epilepsy is the photoparoxysmal response in patients with idiopathic generalized epilepsy.
Do you know how old he was when that started? This been going on?
No, this was, I don't know exactly, but it was in his 30s or something like that. He's a math professor, obviously a Green Bay Packer fan. I don't know if that's dangerous in Seattle.
So how often, what percentage of his chewing causes seizures?
In his case, he had seizures a couple of months on his medicines. So on taking medicines twice a day, every day, and would have these focal motor. There weren't dyscognitive features, but focal motor seizures with chewing a couple of times a month. So he had an ictal spec injection that you saw there, and then of course, we talked about semiology. So we're off to a pretty good start with him as far as semiology, right? Left face with chewing, so should be right hemisphere, probably paracentral lobule region of the brain, and indeed that's what his EEG suggested, even though scalp EEG is not particularly localizing in detail. And remember, his MRI is normal, so there's no operation yet for this gentleman until he is implanted. And this is a rendered MRI with the electrodes placed on the surface of the brain, some an example of a high frequency ripple frequency oscillation in the interictal period. He had functional mapping and went through all this and actually is seizure free. So we show him because that's a huge success story. These patients are extremely challenging, and I'll show you the data on that. Here's the data. So this is what I say is the current state of where we are. We use MRI, functional imaging, intracranial EEG, and in patients with mesial temporal sclerosis, seizure-free remaining over the course of months, roughly 72% are seizure-free. Most patients remain on medication. These are patients with mesial temporal sclerosis. That's fantastic. I mean, the chance that you're going to be seizure-free on a medicine is essentially, adding another medicine is essentially nil. Temporal, normal MRI temporal lobe epilepsy, in our hands, only 55% of those are seizure-free out past 5 years. To me, that's a pretty good deal if it's non-dominant. But when I talk to patients, it's a dominant temporal lobe, looks like their semiology suggestive of medial temporal. You got a 50% chance of being seizure-free, and you got about 100% chance of not having trouble remembering the grocery list. I mean, those are more difficult challenges, but certainly for non-dominant temporal lobe, we do those routinely. And also for many patients decide, even with those numbers, 55% that it's worth the risk. Of course, the lesional patients do very well. So that's if they have a cavernoma. That is a lesion that can be entirely resected. So patients that have MRI abnormalities are way ahead of the group, right? And then what about these extratemporal normal MRIs? Like I showed you the case where it all worked, but the fact is, in the majority of patients, we're not successful with these patients that have extratemporal lobe epilepsy. This is a paper from a fellow. We started with 85 patients in the clinic, extratemporal semiology. 47 of them, we had a reasonable hypothesis. 31 of them ultimately decided to go to intracranial monitoring, big craniotomy, electrodes on the surface of the brain. Of those 31, 24 of them, we could actually localize where the seizures came from, and then 9 of them were actually seizure-free. And my surgeon colleague, we got to do the cost analysis on that. I'm not sure we want to see the cost analysis on that. It's a lot of technology, but certainly for those 9 patients, it's transformative. But it's a lot of patients that go in the pipeline. I show this because just realize that when people report outcomes, most often it's jumped to this number. We evaluated 24 patients and 9 of them were seizure-free. You know, that's not the whole story. Typically, the whole story is a larger number were implanted, but you couldn't localize where the seizures were coming from. So I think it's basically an intention to treat analysis is how these should be looked at.
Did the math professor have any residual symptoms after surgery?
Ah, that's great. Yeah, so he had a facial weakness, but I looked through the residents, the bilateral motor input, they recover very nicely from that. So if you see compared to his driver's license previously, you know, have a pretty subtle facial droop, but really recovered nicely over the course of a year. So he had a lot of things going for him. One, he had this reflex epilepsy, so we had the chance that we could precipitate a seizure and then get an ictal SPECT injection and not have to wait until it occurred spontaneously and come running into the room and get there late, which is what happens half the time. Right at the bedside, we could provoke a seizure. So he had that going for him. And then the location of where the seizures came from, that's a surgically addressable region of brain.
Did you get any histology?
Yeah, it was a cortical dysplasia, which is a little, my experience, that was a little surprising with his later onset, but
That's why I asked about the age concept.
yeah. So I think atypical, but yeah, he'd had that substrate for a long time before the onset, and no head trauma or this is. I think it's a illustrative example. This is not our typical patients that we see, unfortunately. The point here, just most surgery outcome studies are published out to 1 year. We know that we need some time, but the fact is, when we look at these survival curves, what's true at 1 year is not what's true at 5 years. And we were talking earlier just what is going on during this period where patients will have 1 year remissions and then subsequently recurrence of their seizures. So is it brain tissue that previously couldn't spontaneously generate seizures is now able to generate seizures? And many of those patients actually go to subsequent implantation and resection and can be rendered seizure-free with identifying seizures that originate from the border. Yeah.
Once these seizures recur, what frequency are they occurring at? Or do they go back to like a frequent?
Well, it's very variable, but typically, if you nicked it, you're in the right area. Usually, the seizures will have changed, be less frequent. Unfortunately, for patients, often, and I see this with temporal lobe epilepsy, they'll lose their aura, which is, so they no longer have the epigastric rising sensation, the deja vu. They just, boom, fall to the ground and have a convulsion. And those are unfortunate. But, so what about the patients that aren't candidates for surgery? What are the new things on the block? And just this is the anterior nucleus stimulation of the thalamus, not approved in the United States, approved in Europe, Canada, and probably going to see approval here. Really a nice, very powerful, well-designed clinical trial run by Bob Fisher at Stanford demonstrated the efficacy of anterior nucleus stimulation of the thalamus for epilepsy. The device that was just recently approved, we always used to have that, not approved, now we can, recently approved by the FDA is the neurostimulator, NeuroPace responsive neurostimulator. And that device is now approved for focal stimulation. And I'll talk more about that trial and that device. And then more recently, clinical trial investigating forecasting seizures. And I can see that I've got too many slides and I'm going too slow, so maybe I'll probably skip some things. But so this is our first RNS patient, and it's an interesting patient for a couple of reasons. So he had focal motor seizures involving the right hand. He had a kind of odd sensation, and then he'd have right hand and it would spread up the arm. We implanted him with a large grid, got a really beautiful focal onset. So that's all looks great. Of course, to evaluate them, this is what you have to do. So if anyone looks at that and doesn't say, boy, they need a new set of tools, there ought to be a better way to do it than that. But that's currently how it's done. Big craniotomy, large grid, fair amount of morbidity, certainly uncomfortable for the patients. And this patient went through this, and then with stimulation mapping, that same area where the seizures were coming from was motor hand. So he went through all this. A week later, you're not a surgical candidate. And those numbers I showed you of the non-lesional extratemporals, we started with 31 were implanted like this, and only 24 of them we could actually offer surgery to. So it's not uncommon if you're, fairly, not overly aggressive, but if you're evaluating a lot of these patients, that they'll be implanted and they won't be surgical candidates. Until NeuroPace, we really had nothing to offer this patient. So this was our first NeuroPace patient. We liked him for NeuroPace because the seizures are very focal. We know where to put the electrodes. And this is the device. It's implanted in the cranium. It's got a microprocessor. It has a feature, 3 features that you can tune to detect the seizures. So pretty cool. It actually detects the seizures like a cardiac defibrillator, then delivers the therapy to abort the seizure. That's how it's supposed to work. That's the patient in the office. This is just a little bit about the trial, and maybe I'll jump ahead through this. There were 32 centers, so it was really a large, well-designed trial with a placebo arm where they weren't receiving stimulation, and was shown to significantly reduce the number of seizures. We have long-term outcome now out to 7 years, over 1,100 patient years, 58% reduction in seizures, 58% responder rate. Define responders by those that had their seizures reduced by 50%. So clearly effective. I have no seizure-free patients with this device. So, boy, that's a lot of hardware. It's a lot of device. It's a lot of everything to not be seizure-free. 50% reduction, 50% reduction. Well, if I had 10 seizures a month, now I'm having 5. In Minnesota, you got to go 3 months without seizures before you can drive. Currently, well, I don't think we would use the word transformative to describe, but this is a first-generation device, clearly demonstrates efficacy, demonstrates the power. And I have a few patients, that guy I'm showing you, where out living his life, freely behaving human on his medications, and that's the onset of a seizure right here. Within 2 seconds, the device detects the seizure, delivers the stimulation, and stops the seizure. So that's fantastic. Now, admittedly, I have 10 patients and recording for 7 years, and I have about 3 of these. So it's this is the exception, and I being light about it, but the challenge is you've got to have these electrodes right in the region of brain generating seizure. You've got 8 contacts. You can't just lay them anywhere and expect that that's going to be beneficial. And then you've got to do early detection. Once these seizures develop, as happens in this case, you can stimulate all day and you're not going to stop that seizure once it's recruited enough surrounding brain. So what we evolved to with this device is hypersensitive detection. What that means is many false positives, but all of the stimulations are subtherapeutic. So the majority of my patients are getting up to 1,000 stimulations a day. So the brain's just constantly getting tickled with electricity. And that's proven to be the most effective in reducing their seizures. Clearly, they weren't having 1,000 seizures before this started. So we're probably more modulating that epileptogenic tissue than we are detecting seizures and stopping them. Being from the Midwest, you've got to have a barn and a horse picture. So why does it work this way? Well, we operated on the simple idea that the horse is out of the barn. It doesn't do any good to close the door at that time. By the time you detect the seizure, it's already recruited so much surrounding tissue that it's going to be difficult to stop the stimulation. And that's led us to ask how best to record from the brain. What dynamic range what spatial scale should you record at? Do seizures start at a level of a cortical column, single neurons, or can you use these big macro electrodes separated by a centimeter and hope to be able to control seizures? The second area I wanted to talk about is the value of forecasting, the idea of forecasting, and this is the idea that what is most disabling about seizures? The seizures themselves, of course, are disabling, but a patient that entered this NeuroPace trial or the Sante trial or has epilepsy surgery may have 4 seizures a month. They last a couple of minutes, so it's 8 minutes a month. What is it about those 8 minutes a month that is so disabling? Well, when you talk to patients, they don't know when that 8 minutes is going to occur. Seizures themselves, if you knew when they were going to occur, you wouldn't go give that talk that day, or you'd stay home. You wouldn't, obviously you wouldn't drive. Most of the time, patients with drug-resistant epilepsy are in a seizure-free state. Many people are very successful. They're limited by these paroxysmal, possibly random events. Because we don't know when seizures are going to occur, we take drugs twice a day, every day. These for events that maybe occur once a month. You take drugs twice a day, every day. So it's this uncertainty that leads to disability and also, of course, injury. So if you could forecast, if you had like a weather report, the day's going to be a rainy day, it doesn't have to be 100% accurate. If it was as good as the weather, I don't know how your weather prediction is here in Seattle. It's pretty good in the Midwest. If you had some information about when seizures were going to occur, you could adjust your activity. Maybe you'd take more medications, because these medicines you're taking twice a day, every day, most of these patients are on multiple medications, have significant side effects. So if you could take less medicine at different times. So clearly it would be very powerful. The idea is, or the signal that many of us have searched for, is in the electroencephalogram, the idea that prior to the seizure, there's a period, a pre-ictal period, there's a brain state that has a higher probability of seizure occurrence. So from a computational perspective, the question is, can you classify the brain? Can you identify this pre-ictal state from interictal state? And the answer to that question is yes, but it's taken a while to get there. So seizure prediction, are seizures random? There's quite a bit of data to support that seizures aren't random, actually. It doesn't mean that there's deterministic prediction. It's not, we don't have Newton's laws for how the brain functions. We can't predict seizures like we can predict the orbit of the moon, but certainly we can do probabilistic forecasting. And the big success story here, and people always say, what, the weather prediction's terrible. Weather prediction is actually very, very good. And the reason for that is the equations of motion are known. The physics is well understood, the Navier-Stokes equations of how the atmosphere evolves. You can put those into a computer and generate updated patterns. So we have good models. We have very good data at multiple scales. You have satellite imaging, you have wind speed, barometric pressure. So quite good predictions on the weather. It is a success. You got to believe that, because there are many areas that haven't been as successful for prediction, and all natural phenomena is not necessarily predictable. Enormous resources have been put into earthquake prediction. This is the 1906 San Francisco earthquake. All California, detailed sensors along the fault lines, and of course, the next picture is the 1989 earthquake, where there was no warnings at all. So earthquake prediction's really been, in most cases, quite a failure. I mean, a worthwhile endeavor, but has not been successful as weather has. Stock market is the other one, and I won't go into that one. This was a newspaper thing that caught my eye. A really tragic earthquake in I think it's northern Italy, but they actually convicted the scientists because so it gave me pause. Do I really want to try and predict patients' seizures or not? But yeah, so seven scientists were convicted because they didn't provide a warning. They were using earthquake prediction to the best of their ability. This was not very long ago. I don't have a date here, but
Luckily, they were absolved last week in the fields.
is that true? Oh, I'll have to update that. Thanks.
Came a little too late, though. They've been executed.
So seizure prediction is a long history. It's actually quite controversial. Florian Moorman, Bond Group, reviewed this in 2006 in Brain and found flaws basically at that time in all the studies that were done. And the data were really challenging at that time because all we had were data from patients undergoing surgical evaluations. So they were implanted with electrodes, post-op, having undergone anesthesia, their medicines were being rapidly tapered. They were highly enriched in seizures because that's what you're trying to do is capture seizures. But Florian really found that with all of these papers on prediction that none were more convincing than chance. And the quip was, prediction is difficult, especially when it's about the future. Now, this is someone else told me that. No, Yogi Berra said that, but I think we'll give it to Niels Bohr. So forecasting seizures. So NeuroVista was a small startup company here in Seattle. Unfortunately, wasn't successful in raising that second round of capital they needed to keep going. But with the first round, they developed a device. And while we couldn't get it approved in the US, it was approved in Australia and implanted in 15 patients with refractory epilepsy. And it's really just a wonderful piece of engineering. 16 electrodes, acquisition in subclavicular, 400 hertz sampling, telemetry to a handheld device. And the power of this is you're not constrained to the computation on the device. On a handheld, you can get quite a bit of computational power. And you couple that with the cloud, the patient, this is continuous data, it's stored to an SD card, you get a week's worth of data. The patient then takes that card into the laptop and uploads that to the cloud so algorithms can be developed and you continue to capture interictal and ictal data. So you really accomplish this big data that's required for prediction of rare events. Seizures are fairly rare events, not as rare as earthquakes, but they're challenged by the fact to get statistical significance, you need to capture lots of events. So this trial ran through 2011, 2013. Mark Cook was the PI at the he's at the Royal Melbourne, Terry O'Brien at the Austin Hospital, and Sam Berkovic. So 3 Melbourne epilepsy sites. First thing that came out of this, and we knew, people knew this, but the patient diaries are not very useful. So here you have gold standard electrographic documentation of seizures. How did those seizures correlate with what patients reported? Well, there's the data. Not very much. It's an important point because how we do drug development now for epilepsy, you send your patients home and then they come back and they tell you, I've been having seizures or I'm not having seizures. The fact is, not for any reason on the patient's part other than the fact that amnestic events are common in epilepsy. So that was, I think, a useful piece of information. Only 5 of the 11 correlated. I'm going to speed up and flip through these, but this is just this idea of big data that you can forecast. And in these 11 of the 15 patients forecasting horizons, periods of increased probability of seizures over 100 minutes prior to the seizure. We couldn't get it improved in humans in the US, so this was an example of reverse translation. In Australia, they did it in humans. We did it in dogs in the US. So we had a UO1 with NeuroVista, Mayo, UPenn, and University of Minnesota implanted the device in dogs. These are dogs with naturally occurring epilepsy. Everything you know about human epilepsy, just put the word canine in. epilepsy is very common in canines, just as it is in humans. We use the same device. Dogs are a good platform because they can tolerate the human-sized device. And we did a couple of studies. Ned Patterson at the University of Minnesota had the device telemetry to him when the dog had had 2 or more seizures, so a warning that the animal was in status prolonged seizures or recurrent seizures. The outcome of the 6 dogs, seizure prediction significantly better than chance. One very powerful piece was that they had many days when they were in very low probability of having seizures. So it turns out that it may be easier to identify periods where you're at very low risk of having seizures, that you could do that with a higher specificity than periods when you're at higher probability of seizures. Patients would find that very useful. So even though they would have many days of the month when it's uncertain, right now that's how they live. That's how you live with epilepsy. You don't know if you're going to have your seizure today. So if you could offer 5 days, no, very low, 0 probability of having seizures on these 5 days, that would be a very powerful therapeutic benefit.
Do these dogs have generalized epilepsy?
Yeah, so again, some do, and then some have, the majority actually have focal epilepsy. A lot of it, we've set up a network of getting these dogs from breeders that breed dogs for research, primarily for cardiology, I think is their big end user. But often there'll be a flurry of dogs that get seizures with encephalitis. But certainly there are genetic epilepsies in dogs. Again, as far as I'm not a veterinarian, but everything I've read, it's pretty much everything I know about human epilepsy, just put the word canine in. So some are generalized, some are focal. We've studied, these are focal seizures. So epilepsy surgery, device stimulation, seizure forecasting, what do those all involve? As we've pursued them, electrophysiology. How about stepping back and asking, what frequency should you be sampling these signals at? What spatial scale? It's an important question that really remains unanswered. I'll just flip through my last slide so we can get some questions. I told you I had too many slides. Way too many slides. Those last slides were asking this question of what's the dynamic range that you should record from the brain. We talked about that earlier with the residents. The brain generates activity from DC to local fields up near 1,000 hertz. So why does our EEG acquisition system sample at 500 hertz? Well, it used to only sample at 100 hertz. I guess that would be one thing. It's better now. But these are all legacy, engineering legacy is what I would say. So I think it's unclear the clinical utility, but that's going to be something that's going to emerge. And what spatial scale should we record at right now? Intracranial electrodes are spaced a centimeter apart. Well, that's just the way we've always done it. But clearly, and some of the data that I didn't show, electrographic seizures can begin on the scale of cortical columns. I think it would be reasonable if you ask at what scale do seizures begin, to think that a cortical column would be a good functional unit to start with for the generation of seizures. So just to wrap up then, the relevant temporal and spatial scales, as we were just talking about, one thing I wanted to make a big point about is the idea of reproducible research. All this data that we've collected, all this dog data, is available on the IEEG portal for people to use. It's an NIH sponsored electrophysiology platform to accelerate seizure forecasting. And at AES, we'll announced the results of a competition. We had $30,000 in prize, continuous recordings from canines and from humans, and challenged the international community to perform classification, prediction, and detection of seizures. And this was very successful. Over 500 teams participated. They really ranged from all areas of math, physics, computer science. But the teams that won really, in each case, detection and forecasting, had done better than our respective labs had done over the last 4 years. So the NIH is, they see that as a good thing. I think, no, it's a good thing, of course. But it's not that everyone that they did so well. The key thing is everyone's working from the same data. All of the algorithms are available. It can all be reproduced. If you have an algorithm you want to try, you can run it on the exact same data. So the idea in electrophysiology that we make our data available, I think, is very important and very, very powerful. So with that, any questions? Uh-huh.
You didn't mention VNS. Was there a reason?
Just for time, but it's, VNS also has a responsive stimulation component now, and it's under study here, and you guys may know more about this than I do, but I know it's approved in Europe. So VNS stimulation also, and to be fair, and maybe your point, the results of the trials for VNS, deep brain stimulation, and RNS, they're not that different. They're not that different. Certainly VNS is much less invasive. So, thanks. Actually, in the talk I gave last year at AES, I didn't have to, because most of what I work on is this, so I'd left it out, and they actually requested I put it in there. So I did have some earlier slides about that. Uh-huh.
So in the case of these dog studies, has anyone ever tried at the same time, to do all the electrophysiological recordings? You could at the same time basically do metabolomics on these dogs.
Yeah.
And see whether there's any correlates between the periods when the dogs are seizure-free and the periods where they have frequent seizures.
Yeah.
Or you think that the variation in causes of the epilepsy is too big? Such type.
Yeah, no, again, like human epilepsy, it's the lungs cough when they're irritated, the brain seizes. So I'm sure it's wide, but I think the dogs certainly are a very interesting group, and we've just actually started a study looking at serial CSF studies, looking for immunologic changes at baseline and periods of seizures. Most of these dogs have seizures about once or twice a month. And metabolomics, epilepsy surgery, device stimulation, I think these are all things that would be interesting and useful things to pursue in the dog model. We were laughing the other day. What's truly eloquent cortex for the dog is probably olfactory lobe, right? That's probably their hippocampus. Uh-huh.
I haven't thought about phenomenology of epilepsy in a long time, but I know it used to be said that people with partial complex seizures, temporal lobe epilepsy, there often was a skew in that population with sometimes fairly serious personality and psychiatric problems. Is that still true? Is that still the case, number one? And number two, if it is, does that improve when you control their seizures?
Yeah, so a lot written about the temporal lobe personality, and certainly, we often see patients with temporal lobe epilepsy that will have post-ictal psychosis. Certainly depression. The majority of the patients that I see in my clinic have depression. The comorbidities are enormous.
Should you just, and the reason I'm asking that question is because I personally know a young man who has that kind of seizures and has terrible depression. So is anybody able to sort out, is that a response to having epilepsy that's poorly controlled, or is it part of the brain disease?
Yeah, it's complicated. I don't have an answer for that.
Right.
But the same limbic circuits that are responsible for the seizures are the circuits that are involved in, we think, in mood disorders. I've had it go both ways, frankly, in clinic. I've had patients rendered seizure-free after temporal lobectomies and have the worst depressive episodes that they've ever had, and end up in the psychiatric hospital, and even a couple of them have had ECT, which, really just rattles your soul when you think, boy, we've offered epilepsy surgery to this person, we've stopped their seizures, and now but in some of these cases, you're really, really challenged.
Stimulation may be therapeutic.
And stimulation may be therapeutic. So I don't have a...
You have a question from some of your distant admirers.
Okay. Oh, am I supposed to read that? Right. Can you comment on how important it is to localize the seizure focus for RNS and prediction? And for RNS, the device works by modulating, in most cases, that ictal onset zone, and in some cases, detecting early seizures and stopping the seizure. So it's absolutely critical. I think that's the technological advantage that DBS has over RNS is with DBS, it's all anterior nucleus of the thalamus, or if you wanted to do centromedian nucleus of the thalamus, the anterior nucleus of the thalamus results are fairly similar in terms of the responder rate. A real challenge with RNS is that you don't always know where the seizures are originating from. So how we've used RNS, the patient that had bilateral mesial temporal sclerosis, can't offer them surgery, but I can be confident that the generator of the seizures, mesial temporal lobe, can implant them to be sure of that. But in a couple of patients, we've just gone directly to after scalp recordings. So in those cases, and then the patient I showed you where we showed focal seizures originating from eloquent cortex. Historically, we had nothing to offer those patients. RNS is a good option for those patients. But yeah, so it's a great question. Absolutely critical for RNS. For prediction, I'm less certain. My guess is, my thinking is that you want to have electrodes in the seizure onset zone, but we have much less evidence to that effect. The dogs that we forecasted their seizures are not all particularly well localized, but they have more generalized changes in their electrocorticographies that are associated with the propensity to having seizures. And what are those changes? The features that have been most successful in the guy that won the prediction contest and got $20,000, that's pretty good, using bivariate synchrony measures in different frequency ranges. So nothing super sophisticated, but that there are clear changes using machine learning classifiers that you can identify. And again, driven by this massive amount of interictal data. I didn't go over it, but the dogs, we've been recording them for over a year. So you have over a year of interictal data So all the dynamics that the brain's going to do, you sample most of that, I think, in a year. And then you also have a large number of seizures. The dogs had a couple of seizures a month, so most cases you have 20 to 30 seizures to clip out this preictal period, train your classifier compared to the interictal. But so how important the seizure onset zone is for that technology, I'm less certain. But I think it's going to be helpful.
You've probably, for years now, we've appreciated that sleep deprivation is a risk factor for having a seizure. And recently, there's been some very interesting work showing that during sleep, there tends to be much more circulation of CSF through the parenchyma of the brain. This is the work of Mike and Nittergaard that's attracted so much attention, these multiple Nature Science papers on the subject. So it strikes me that one of the things that sleeplessness does is it tremendously aborts the circulation of CSF, this cleansing, brainwashing circulation of CSF, which could lead to an accumulation of something that predisposes to neuronal hyperexcitability. So first of all, your comment on that idea, and second of all, maybe the proximal event, and the way to think about it would be to put in some cannulas and regularly sample extracellular space contents, not just potassium, but lots of things that may well affect in subtle ways, and maybe not so subtle ways in cellular.
Yeah, I'm not, full disclosure here, I am not wedded to electrophysiology on this problem. And so I think there are a number of opportunities to look for other signals. The idea of the CSF circulate, I mean, it would not be, one problem I've had, so I have a colleague who does neurotransmitters and uses a technique to measure neurotransmitters. One challenge is a sampling issue, it seems to me. You know, the local fields, those are quite distributed by the nature of electricity. How, and I don't know the answer to this, if we have a couple of cannulas into parenchyma, do we sample a couple islands that are not very, are they going to be representative of the tissue?
I don't have the answer to that. Obviously, there would be some sort of equilibrium between brain extracellular space and a small lake that you would create with these cannulas. It's a step better than CSF. CSF is a far distant lake. This would be a much closer in sniff of what was going on. It seems to me it might have merit. You know, it's not as if you know, the doors are breaking open with new technologies that are hugely promising. Rather, they seem still a reach.
Yeah, they're still pretty modestly promising, I think. Yeah. Oh, that's those are interesting thoughts, and I've often, for the glia, epilepsy probably. Yeah. I remember being on study section with Micah. She sat next to me and just, epilepsy is a disease of glia. It's a disease, and I tend to agree. Even I think that in many cases that's probably the.
I would accept you again into this residency. Thank you so much.
I could be retrained. Yeah. Thanks.